Hi. Hello. Hi. Welcome. Hi. Okay. I am jumping on here to talk about my favorite topic to talk about. And so we're going to get Dr. Sarah Cox on here, psychologist at Gallia Collaborative. So let me send her an invite. And she's coming. Hi,
Hi, Sarah.
you made it.
Hey, yeah,
How are you?
I'm doing well, thanks. How are you?
I'm doing just fine. I'm drinking hot coffee or hot water, which is my new favorite thing.
Oh,
No, it's not new. I've been drinking hot water forever, but I'm freezing, even though it's actually like warming up outside.
I know. I've been drinking my hot coffee, so
Uh,
I'm with you on that.
I know. I already had 2 cups of coffee today.
Yeah.
I'm like, I can't keep drinking more coffee. Well, I am very excited to chat with you. Well, we talk about this all the time, but now we're just going to let other people listen to us.
Great. That sounds good.
So, do you want to introduce yourself?
Sure. I'm Dr. Sarah Cox. I'm a clinical psychologist here at Gallia Collaborative. And one of the things I specialize in is supporting people with a variety of health concerns, particularly things like health anxiety and chronic health conditions, but also chronic pain, which is what Sarah and I are here to talk about.
Yeah. So, for those of you that don't know me, I am a doctor of physical therapy and have spent, I don't know, the last 10 years specializing in the treatment of chronic and persistent pain. And I think what's important to realize is that chronic pain isn't as chronic as a lot of people think. I think people think of chronic as being years, and truly by the definition, it's 3 months. And some scientists will even say 10 days, which is crazy. But yeah, so chronic pain is pain present for more than 3 months and wildly different than acute pain. I use the metaphor all the time that, acute pain is like, ow, I put my hand on a stove. And chronic pain is, ow, the stove hurts and you've only stepped into the kitchen.
It's a great analogy.
So, yeah. And so what you and I are frequently talking about are the multidimensional aspects of pain. And so what do you see in your office? When you're working with clients, what is it that what are you looking for? What are you dealing with? What are you getting clients to work on?
Yeah, I think by the time that someone maybe comes to me specifically with chronic pain and all the repercussions that come with that, they have been suffering for quite some time. And that suffering might look like physical pain, but it's often all the repercussions that come with it. So we know that folks who have chronic pain are much more likely to experience depression, irritable mood, anxiety, maybe even anticipatory anxiety. So even if they're not in pain in that moment, like worrying about the next, activity or stressor where that pain might be evoked. We know that there are sleep and appetite changes, and then just quality of life impact with chronic pain. So people often and understandably work really hard to not feel both the physical and emotional aspects of that pain. So they might stop doing things that are important to them. They might have shifts in work or relationships, or stop doing, physical activity that typically they enjoy or makes their body feel good. So by the time I see someone, often their quality of life is really diminished in lots of ways. And so we're trying to use some evidence-based strategies so that they can manage the symptoms, but also respond to those symptoms in a different way to have a more meaningful, fulfilling life.
Yeah. So I think another really interesting piece where I'm trying to educate people is pain typically begins somewhere organic, right?
Mm-hmm.
It started with a really bad car accident, or it started with a trauma, or even repetitive stress.
Yeah.
A high stress job, caring for an aging parent, you name it. So this recurrent stress will wear down the soft tissue, the joints, the uh, peripheral nervous tissue, our peripheral nociceptors, the little free nerve endings in the skin that pick up and identify the environment. And so those old traumas, old stressors, when they are present long enough that they cause a central nervous system change, a change in the brain, we need what you work on from a behavioral standpoint, an acceptance standpoint, coping strategies. But then we also have to come back and address the peripheral nervous system and put out that fire that started it organically, even though the tissue might be healed, even though the scars closed, even though the muscles regained full strength. There's still those little free nerve endings that pick up a sharp knife or a stabbing sensation or a burning sensation, even though it's just your bra strap. And so I think what's interesting is and what a lot of people don't think about is both the cognitive aspect of pain as well as the peripheral aspect of pain.
Sure.
Which is why you and I talk so frequently about the need to have in a condition, in a case where you have chronic or persistent pain, really the need to have both a therapist and a physical therapist on board. So give me an idea of some tools that you're going to be working on with somebody.
Sure. So just to piggyback on this idea that pain impacts our nervous system, and then we create relationships between our thoughts, the physical sensations in our body, our emotions, and then our behavior, how we respond. So if we use that stove metaphor, right, that process in our brain and body can be really important and adaptive to keep ourselves safe. But when we have chronic or persistent pain, we are probably not in a state that we're actually in danger or threat, but our brain and body thinks that we are. And so that really carries over into how we think. So the nature of our thoughts, part of what we'll be working on is learning how to identify some of those patterns of unhelpful thinking that are keeping us stuck, and then responding differently to them. So sometimes that might mean challenging them or gaining some perspective and interrupting them. Sometimes that might mean using more of a mindfulness approach and knowing that those unhelpful thoughts might be there, but you can work to let them pass so that you can still go forward and do what you need to do, because we know that actually you're okay and you're not in danger or threat. You've just stepped in the kitchen.
Right.
Sometimes we're going to be using a strategy called ACT, or acceptance and commitment therapy. And what that really means is we're going to be doing work to clarify your values. What's important to you outside of pain, which might feel all consuming? What's actually going to bring you meaning in your life? And how can you work toward that, even if it has to look different? So even if we have to do maybe some pacing strategies in our behavior change, or even if we have to take breaks or do things at a different frequency or in a different way, we still want to work toward the things that bring us joy.
Yeah.
So it's usually a combination of addressing the suffering, which is the emotional response to the pain, and dealing with the thinking and behavioral components of that.
Yeah. I use this analogy often too when I'm working with people, because people who have been dealing with chronic pain for an extended period of time get really comfortable with it, and they almost wouldn't know how to act or behave without that pain. And so I often use the analogy of like, move next door. So you'll still live close to your pain. It'll still be there, but you're going to move out. But you'll just move right next door. And, a lot of the things that I work on are sensory retraining. So retraining those nerve endings to perceive light touch, vibration, deep pressure, pinprick, movement. And then we're talking about exactly like what you just mentioned, dosing. So, okay, let's start with a 5-minute walk. Let's start with swimming 3 laps in the pool, or jump on the bike. And then we build from there. But, you know, just like you would if you had a shoulder surgery, you have to, you know, rebuild your endurance. You have to rebuild your strength. You have to all of that, even though the real initial injury has probably been said and gone. But people tend to really become attached to their pain. And I think this is where the role of 2 providers is just so important because, you know, I think when you're treating just the sensory component of pain, you can get so far. If you treat just the cognitive component of pain, you can get so far. But that sensory component will keep the fire burning, or the cognitive component will keep the fire burning. So unless you really address them from both directions, something's always going to still be burning.
Sure. I'm with you on that. I've definitely had that experience too.
Yeah. What I also think is very interesting, and something I'd like to hear how you handle, are those like invisible diseases. So those people who look incredibly healthy, and maintain normal full lives and work still and go to their kids, you know, soccer games, but they're still living in pain. What does that person look like to you, and compared to maybe the person who's, you know, clearly disabled by pain?
Yeah, I see that a lot. You know, our practice really specializes in working with women, and particularly for women, I see, you know, moms who are caring for, as you said, aging parents or children, or they're showing up to work, or they're doing work at home. And yet, like, they function with their pain and almost accept it as a norm. And it becomes part of their, you know, lived experience. But I find that it can be really invalidating for people, because unlike an outward sign of pain, like maybe using an assistive device, or having an obvious shift in your physical presentation or in your gait, folks who have invisible pain don't often get the empathy or sympathy or external supports that other folks who have more obvious forms of pain might experience pretty naturally from our families or our communities, or even from healthcare providers. So I find that, you know, not only my validation of the person's pain, but also teaching them how to acknowledge and validate their own experience, and even learn how to communicate that to others and ask for what they need in terms of support, in an explicit way, especially if they're not receiving that. That can be so important and meaningful for invisible pain.
I also see this kind of hidden guilt when you're somebody who lives in pain but you're functional, where like I'll hear, especially women, who will be like, no, it's fine, like I've had this forever, it's fine, because they don't want to complain, right? Or add something else to their plate, like, well, I can't handle this right now. I've dealt with these headaches since I was 16 years old. I figured out how to deal with them. And then you start asking really particular questions, and like once a week they lock themselves in the room, close the door, and turn off all the lights. And you're like, well, that's not really like interacting with your family and, you know, being present in everyday life when you have to close yourself in a room 1 day a week. But there's this level of I'm not that bad. And I think that's the topic that I spend so much time like talking about, because that like not that bad today turns into like, oof, I'm a little bit worse next year, and like, oh gosh, okay, I'm quite a bit worse like in 10 years. And that coming back process, that unwinding that ball, beyond the physical part of it, cognitive, like all of the compensatory strategies that somebody makes from a behavioral standpoint, where not now all of a sudden they won't go to their kids' gymnastics meet, and they won't go to their family Christmas party, because all of that sound or all of that interaction or all of that heaviness of the talking and trying to be positive is too much.
Sure.
And I think women especially need that, like, that little bit of rope to say, you know, you're allowed to admit that you're in pain.
Sure.
And I think
Yeah,
men
and I mean,
do, but obviously.
No, I mean, think about all the systems that we as women in particular carry that might contribute to that narrative or tell us that maybe we aren't worthy of justifying the time or money or energy it might take to get the care that we need, whether that's physical medical care or psychological medical care. You know, I think sometimes women tend to put themselves on the back burner, or we rationalize or we justify, and that's part of the coping, right, with having pain, but also other demands. But as you said, it can catch up with us and really be a disservice if we don't take care of our own needs.
Right. And it's, you know, I think the point that you and I both want to like drive home is that pain yields anxiety, yields depression, yields anticipatory anxiety, like you were describing, behavioral changes, avoidance, and it changes our, you know, our everyday interactions with our environment. And at the same time, peripherally, we're keeping that fight or flight, our sympathetic nervous system, ramped up, which delays healing, impairs sleep, impairs normal hormonal physiologic processes.
Sure.
And so there should be this like urgency to deal with pain, and yet we still find excuses to just kind of deal with it.
Sarah, how do you invite your patients to take that time for themselves, or how do you help them take the next step, you know, when they might be stuck in the way that we're talking about?
You know, a lot of times I offer them hope that they can feel better. I think
so important.
Many times they think that because it's been there for so long that it's just their lot in life. And so I take a lot of time to explain what, you know, pain science is and what happens physiologically. The difference between, I say often that like acute pain is like the metro and chronic pain is like the Amtrak. You know, so it's like this much faster process. It doesn't, it gets to the brain so much faster and on this deeply embedded pathway. And so I explain pain and where it comes from. And then I give them hope that there's a chance that they don't have to deal with it forever. And then, you know, I explain really the need for a multidisciplinary team, because very, very rarely am I seeing somebody who doesn't have associated anxiety or depression.
Which makes sense based on the research, right? I mean, and just in lived experience, like how could one not have some symptomatic and sort of functional impact from their pain?
And a lot of times, unfortunately, I find myself undoing this like self-fulfilling prophecy that these individuals have been handed by their previous medical team. Because our medical society is handcuffed by gold standards. So if an MRI, an EMG, an ultrasound, failed surgeries, if those things don't fix it, then your pain doesn't exist, which could not be farther from the truth. And then you take somebody who's hurting, who literally has pain, and a medical provider says, it's not really there, sorry. But here's some meds and good luck. I'll write you a letter for disability. That person then in their mind is like, well, I can't get better. And, you know, you've got the two, like I often see these two different groups of people, like these people who accept that and just, okay, this is it. This is what I've got. And then you see that other end of the continuum where they're like, no, I'm going to figure this out. and then they try everything under the sun.
Yes.
Which is great. They should be empowered and enthusiastic to take their health into their own hands. But then we get into this dark hole of looking for this magic bullet. And at that point, there's no magic bullet.
Right, for sure. And that sort of contributes to all those efforts to control pain or eliminate pain or, avoid. And then there's a hopelessness that comes with that constant seeking and searching.
Yeah.
And I see a lot of folks then who sometimes develop health anxiety as a result of that. And as a result of those interactions where there's no data or lab work or imaging that supports their experience. So it can sort of end up contributing to that story that's part of the problem already.
Yeah. I will frequently have people come into my office and we won't even get through our subjective evaluation in the first visit, an hour long, and I've still got a ton more questions. And what I'm asking is like, what have you done in the past that has made you feel better? And what have you done in the past that's made you feel worse? And, they'll rattle off their laundry list. A lot of people will come to me with like a folder this thick and we'll talk about it. Like, okay, injections didn't work. Good. That's off the table. But I went on vacation and I felt amazing. Okay, well, let's go on vacation again. And if you can't physically go on vacation, well, how can we get you there mentally? And so, we're talking about like, do more of the things that make you feel good, less of the things that make you feel bad. But then I'll also at times say, look, we have to stop all of this. There are like way too many cooks in the kitchen. There are, and a lot of times I'm talking to that person who is doing the CBD, they're doing the acupuncture, they're getting injections, they're on pain meds.
A lot of seeking or like safety behaviors.
Exactly. And so we talk about like trying to pull away from some of those techniques gradually. Like I never just say, okay, let's just stop it all. Because to your point, that would be far too big of a shift and it'd be far too radical. So we talk about, all right, like, can we dose you down off of the gabapentin? Can we slowly take you off of that? Can we, oftentimes we're talking with the physician about maybe adding an antidepressant if it's not already there. Because I think you probably see this more than I, but there's such a negative stigma with antidepressants. And so what I often explain is the role of antidepressants with the nervous system. And I'll often say like, look, maybe psychologically you're not depressed, but your nerves are. Your nerves are to the point they're so dampened that they can't accurately perceive your purse on your shoulder or your socks around your feet, that they're perceiving that as danger. And we need a therapeutic intervention to change the chemistry around those nerves to allow them to accurately perceive their environment. And so, a lot of times we're giving them safety and security and letting them choose because they've studied what's worked, what hasn't worked. And they know what makes them worse for sure. And so we take that out, like, okay, so going to your boot camp makes you worse. Great. Let's not do boot camp. But if you can walk at the park, you feel fine. Okay, let's do more of that.
Sure.
And then a lot of my treatment is really collaborating with the behavioral health professional about what goals are you working on? Where are you in your treatment? Are we working on acceptance? Good. I need to mirror that language. I need to be teaching what happens if this pain never goes away. How do you get used to living if this is exactly how you're going to feel for the rest of your life?
And living well, right? So not just like surviving, but how do we maybe thrive? How do we experience joy and know that might look different? As you said, we might have to really adapt to that.
I had this patient and just the other day, and it was a very complex case. And my homework for her was, okay, I need you to go home and pay attention to the things that make you feel good. And she was like, oh, nothing does. And then I'm like, okay, well, how about petting your dog? Oh yeah, I do really love brushing my dogs.
Mm-hmm.
It's like, great, brush your dogs every day.
Mm-hmm.
Sit with your dog on your lap. How about coffee? No, I don't like coffee. Okay, is it a beer?
Mm-hmm.
Great, have a beer.
Mm-hmm.
And it's like, I always have to use that like asterisk, but
Mm-hmm.
people become so defeated and
Mm-hmm.
wrapped up in their pain that they forget about the like everyday simple joys. And then
Sure.
I describe to them what happens neurochemically with those simple joys. Like what
Mm-hmm.
happens with that endorphin release, what happens with norepinephrine and adrenaline, and how we
Mm-hmm.
need more of that, but not too much of it.
Right.
So, I think I take the opportunity to educate them on what just satisfaction does.
Mm-hmm. And I think to your point, like that all or nothing thinking that really shows up with depression and when our body is not regulating the nervous system very well. I mean, it's hard to attend to any middle ground. And that's part of why we use mindfulness to start to almost reacquaint yourself with your body and actually bring intentional awareness and attention to what's happening, like those micro moments, whether they're sensory or cognitive or what's happening in your emotional state. I mean, we most often don't pay attention to that unless we're asked to. So you're exactly right. Like just trying to expand people's horizons about that and get them to think and live a little bit more in the gray is so key, because we know there's going to be some discomfort, but we also know that there are periods of relief. Often when you ask people, well, when do you not have pain? They'll say, well, I always have pain, but it's not always a 10, right? Maybe sometimes it's a 3 or a 5, and maybe sometimes I can do some functional activities and sometimes I can't. And so those experiences are different, and we need to take advantage of that. But it can be hard.
Well, and I think people just need permission and they need hope. They need the chance for somebody else to believe them. Especially those people who have been through the medical ringer, right? They're the people who have been to Mayo Clinic, they've been to Cleveland Clinic, they've been to Ohio State, they've been to everyone here in town. And to date, nobody's given them hope. And because we're relying on external interventions to be the solution, when really, truthfully, the solution is probably internal. I think one thing you and I both use frequently are breathing strategies.
Absolutely.
And I think, for anybody who's joining us today, if there's anything you can do to keep your nervous state calm, it's breathe. I think a lot of people, probably even just in listening for the last 30 minutes, probably haven't taken a really deep breath. And it's so interesting, the calming effect that a really deep diaphragmatic breath has. And it's funny, I describe it as the vagus nerve, which is part of the parasympathetic nervous system, lies directly behind the diaphragm in the thoracic region, so in the mid-back, but on the front side of the spine. So with every deep or full expansion of the diaphragm, we get this massage to the vagus nerve. And that vagal massage is really inhibitory for that increase in sympathetic tone. So it really brings down that sympathetic tone. Right. So, one of the key things, literally like one of the first things that I'm sure you and I both do with people is teach diaphragmatic breathing.
Right. What I also think, not only is it so effective, but it's always with us. And whenever I talk about deep breathing, I find that there's a pretty widely held myth that we need to be like in a dark, quiet room with our eyes closed, like sitting on a meditation pillow. No, this is the most accessible tool, which in fact our body is built to be able to do, to help us, right, to re-regulate us. So, I mean, so often I just encourage people, like, build this into your routine while you're drying your hair, while you're driving your car. Like, practice this when you feel relatively okay and relatively regulated, so that when you need it, it feels familiar. And yes, it's great to practice deep breathing in a formal way, but if we only do that, we might not ever make time or space or prioritize it. So actually being able to take those deep breaths, eyes wide open, in a way that you can access that tool whenever you need it is the most helpful. That's what I see anyway.
Yeah, you're so, I mean, I remember thinking that myself about meditation. To
Sure.
meditate, I had to spend 10 minutes in a dark room with no
Mm-hmm.
thoughts. And it's like, that's
Mm-hmm.
not meditation. So again, it's
Mm-hmm.
just like the powerful benefit of seeing a really good therapist, and seeing a really good physical therapist or a really good doctor or a really good,
Mm-hmm.
whoever it is.
Mm-hmm.
They're going to debunk these myths and teach you accessible, achievable, measurable tools
Mm-hmm.
to help you overcome whatever it is you're dealing with. But do you want to share about your Thrive Circle?
Yeah, at Gallia, we do Thrive Circles, which right now are virtual groups where we get together in small numbers to learn some evidence-based, meaning based in research and science, ways to respond to different problems. So we have several starting this spring, but the one that I'm facilitating is living well with chronic health conditions. So that might be pain, but that might also be another condition where maybe pain isn't the primary source of complaint, but you're living with a medical or psychological condition that might be around forever or has been around for a really long time. And so we're going to talk about some of the strategies that I mentioned today, like regulating our body, mindfulness, how do we clarify our values and move forward in meaningful ways. I'll give you lots of tools for that and handouts and things that you can be practicing at home. And it's also a nice space I found in doing this group in the past to just find other people who are in that struggle with you. So they might have a totally different condition, but to realize, oh man, like I'm not alone. There are people out there who are experiencing this type of suffering, and that can feel so validating. That in and of itself, I think, has a little bit of a calming effect to realize like I'm not broken, I'm not approaching this wrong, but I just haven't found community around this. So we'll be
Yeah,
starting that up soon. Check out our Gallia website if you have questions about signing up.
good. And then Sarah and I are working on like a 1-day workshop, um, kind of a consolidated version of
Yeah.
both what you are doing through your Thrive Circle and then kind of what I do in individual therapy. So be on the
Mm-hmm.
lookout for that. And as always, send us
Yeah.
any questions. But Sarah, I'm so glad to talk to you about this. You're a wealth of information.
Oh my gosh, Sarah, thank you so much for having me. I'm excited. Our group or workshop, whatever we end up calling it, will be focused on chronic pain. So if
Yeah,
pain's your specific issue, like look for that from the two of us too.
perfect. Well, have a good day, and I'm sure I'll talk to you
Thank
soon.
you. All right, thanks, Sarah.
Bye-bye.
Bye, everybody.